It's a big honor for me, especially, and for other institute. And the final lecturer is Professor Ekaterina Upryamova from D.O.Ott Institute for Obstetrics and Gynecology and Reproductive Medicine, and she serves as chef of the department for anesthesiology and intensive care, and not only scientific department, but clinician department. And her lecture is entitled New Approaches to Labor Pain Relief. Please.
Okay. Thank you very much, dear colleagues. Good afternoon. Now, welcome to my presentation. And now we're discussing about most important, most popular topic in obstetric anesthesiology is new approaches to labor pain relief. Okay, I represent the leading and oldest center providing obstetric and gynecological care in the Russian Federation, OASAO Research Institute of Obstetric, Gynecology and Reproductive Medicine. Our center has also the largest biobank in Russia, and our genetic team conducts a wide range of genetic studies, including those focused on the genetic aspects of labor pain, which I'm going to discuss today. Everyone knows that labor pain is the most severe pain ever experienced by women. It can be compared to the limb amputation or a surge burn degree, but importantly, labor pain causes acute stress during labor, which leads to cascade of pathological reaction and fetal acidosis. And it's important to note that approaches to labor pain relief has evolved over the time. We are all familiar with the biblical phrase, "In pain you will bring forth your children." And if we back in time, there was indeed a certain era characterized by a rejection of labor pain relief, and this approach was considered normal. Then comes the traditional era characterized by implementation of continuous epidural infusion analgesia in everyday obstetric practice through standardized protocols. And finally come modern approaches. What are the most interesting advantages of today we have today on modern approaches? Of course, those include personalized analgesia, taking into account the genetic aspects of labor pain in women, the widespread use of alternative pain relief methods, and the most importantly, the use of the most advanced neurorectal analgesia for labor, for example, program intermittent epidural bolus. Is it worth nothing? A significant increased publication on labor pain relief over the 100 years past. The infographic from PubMed database shows that the number of publications of labor pain relief currently outnumbers of other topics in obstetric anesthesiology. Modern approaches to labor pain relief include using of artificial intelligence, genetically based pain relief methods, popularization of alternative labor pain relief methods, and improvements in neurorectal analgesia. Okay, artificial intelligence in obstetric anesthesiology. How is actively implemented in different areas, and how is AI applied in obstetric anesthesiology? First, this includes the use of chatbots and interactive avatars to provide information about different pain relief methods during labor. You can see the image of an interactive multilingual avatar. Furthermore, modern chatbots have demonstrated high content credibility index and good user experience. Another application of artificial intelligence is predictive analytics or early warning on maternal complication. AI-based pain intensity prediction and personalized pain relief protocols are our near future, allow us to predict the need for analgesics with an accuracy of up to 85%. 5%, significantly reducing the incidence of inadequate pain relief and thereby transforming reactive analgesia into the proactive one. Different chatbots, for example, GPT chat, can indeed be used to provide women with information regarding different labor pain relief methods. Here is one of the latest studies of the effectiveness of GPT chat. The chatbot was asked to answer 10 clinical questions most frequently asked by our women. Then each answer of the chatbot was rated by experienced anesthesiologists for safety, for accuracy, and completeness on a 5-point Likert scale. What were findings of this study? The first fourth-generation GPT chatbot can indeed be an available tool for anesthesiologists, especially in the limited time settings, to provide women with information about pain relief options during labor. However, it should be noted that only 73% of answers provided by GPT chat was considered safe. Therefore, it was concluded that this chatbot can indeed be a useful assistant for patients, for women, for partners, and anesthesiologists, but require further optimization. However, when comparing different chatbots such as GPT, Claude, Copilot, or Gemini, it was shown that GPT and Claude have the best content and communication quality over 18%. A cross-analysis has shown that the highest response correlation was observed between GPT and Claude chat. In any case, whether or not use chatbot in our daily practice or whether or not to recommend it to our patient depends on doctor, on physician individual preference. And let's move forward. The next modern approaches to labor pain relief is preliminary assessment of the genetic aspects of labor pain in our women. The genetic aspects of the labor pain are a rapidly developing field in the intersection of obstetrics and genetics. Research has shown that individual pain intensity have a genetic basis. Among the main genetic factors influencing the perceptions of labor pain is the catechol or gene methyltransferase gene, one of the most studied genes associated with pain intensity. It is responsible for an enzyme that breaks down catecholamine and estrogen. A specific variant of this gene has been shown to result in 40% reduction of enzyme activity, which leads to increased norepinephrine levels in synapse and clinically manifests of increased pain intensity and more severe pain during labor. The next groups are genes associated with connective tissue structure. It is important to note that labor pain has not only neurogenic, but also visceral and somatic components, which depend on tissue elasticity. Accordingly, a woman-specific genotype can increase joint mobility, tissue elasticity, and ensure faster cervical dilation due to easy tissue stretching. The next groups of genes responsible for pain modulation is the ion channel genes, which are still poorly understood. Mutations of this gene can cause more severe pain in women during labor and require early and more intensive pain relief. Well, and finally, the most studied gene, the gene encoding mu-opioid receptors, the main target of opioids. Carriers of G allele have been shown to have a lower receptor density, and women with this allele therefore experience less effective epidural analgesia with opioid as adjuvant, or a shorter duration of effect from parenterally administration of opioids. Studies have found a link, a correlation between a polymorphism in the gene encoding mu-opioid receptors and the need of opioids, consumptions of opioid for labor pain relief. Specifically, it was shown that women with G allele required highest doses of opioid for pain relief compared to patients with the A allele. And how we can use our patient genetic determinants in clinical practice. Preliminary genotype testing of each patient before labor allow us to select the most effective individualized methods for labor pain relief, such as opioid or epidural analgesia. Our center's genetic lab and ability to determine a patient genotype allow us to implement the principle of personalized analgesia. Currently, this is our research rather than routine practice, but we hope that this service become more accessible in the near future. And we move on, and now to next modern approaches is the labor pain relief, which are very much in demand today. Those are alternative methods of labor pain relief. This includes different techniques. You can see this technique on the slide, but the most progressive of these is the use of virtual reality. It should be noted that over the past 5 years, publication trend in PubMed database is significantly, you will see that half of these publications of labor pain relief are devoted specifically to alternative methods. We should understand that alternative pain relief methods don't have an analgesic effect. The primary effect is to reduce pain, anxiety in parturients, and stress in parturients, which provide for decreases labor pain. Giving birth on a beach, women's experience of using virtual reality in labor showed that the most enjoyable images to view through VR headsets are trophy islands and swimming with dolphins. 97% of women who use this method during labor reported that it allowed them to feel more comfortable, more calm, and escape from the hospital room in a wonderful life. Furthermore, a large meta-analysis, including 12 studies, showed that virtual reality does not affect on obstetric outcomes. This technique is safe for patients, and of course, it helps reduce anxiety in women and therefore the severity of pain perception during labor. But we should be considerate when using alternative labor pain relief methods. First, these methods are generally suitable for the latent phase of the first stage of labor and are subsequently combined with standard pain relief methods. Indeed, our study showed that using an alternative technique such as TENS, transcutaneous nerve stimulation, allow us to delay the onset of epidural analgesia until a later stage. Why is so important for obstetric practice? Because not all obstetricians are ready to initiate epidural early unless the cervical dilation is 4 centimeters. Therefore, an alternative technique in this situation allow us to delay the onset of epidural analgesia. This conclusion was confirmed by our Chinese colleagues who demonstrated that combination of TENS technique with epidural analgesia allow us to achieve optimal pain relief mode and low incidence of instrumental birth and side effects. And so finally, the most progressive, most modern methods of labor pain relief is mobile neuroaxial analgesia or walking epidural. It is important to note that approaches to labor analgesia, to labor epidural analgesia have changed significantly over the past 100 years. And 2004, the most advanced methods of labor pain, programmed intermittent epidural bolus, was introduced. This represents a breakthrough technology in obstetric anesthesiology, and today this is still the most effective method of labor pain relief. In 2017, a new modification of spinal epidural analgesia was introduced, dural puncture epidural analgesia technique. Dural puncture is performed without the administration of local anesthetic. However, due to the defect in the dura, local anesthetic penetrates intracerebrally, thereby increasing speed and quality of neurorectal analgesia. The onset of analgesia is accelerated and coverage of sacral segments is improved, and risk of unilateral block is reduced compared to traditional infusion epidural analgesia. They combine with PIB technique with dural puncture epidural, accelerates the effect onset to 10 minutes, while the quality of maintenance analgesia is significantly higher for 10 or 12 hours compared to continuous epidural infusion. And finally, at the December 2025, our Chinese colleagues presented a study on the use of double dural puncture epidural for labor pain relief. They demonstrated a nearly twofold increase in adequate analgesia in contrast to epidural analgesia with comparable local anesthetic consumption. However, this raises the questions. Is it advisable to puncture the dura mater twice? It's a normal technique or not? The dura mater is not too safe, and in April 2024, Professor Carvalho from Stanford University published a review of this study, stating that a single puncture is sufficient to achieve adequate analgesia, and that this technique is not applicable in everyday clinical practice. It remains purely scientific research. Speaking about modern approaches to labor pain relief, it's necessary to note that we observe how approaches to use of local anesthetic and their concentration have changed. In the past several decades, we stopped using high concentration of local anesthetic in favor of low or minimal low concentration with combination of short-acting lipophilic opioids. A systematic review you can see on this slide comparing low and high concentration of local anesthetic for labor epidural showed a significant reduction of incidence of mortar block, assessment of vaginal delivery or cesarean section, incidence of cesarean section when we use low and ultra-low local anesthetic concentration. By using new modern approaches, epidural modes and low concentration of local anesthetic, we can use early epidural analgesia up to 4 centimeters, reducing the level stress response without affecting obstetric outcomes such as cesarean section, instrumental burns, and duration of second stage of labor. It has been shown that we later start epidural, the higher the maternal stress level. The strategy for selecting the optimal methods for initiating neurorectal analgesia is based on 3 main criteria: the required rate of analgesia onset, the stage of labor, and the intrauterine condition of the fetus. We can begin pain relief with early or late epidural analgesia if the parturients show regular contraction and pain intensity over 14 by VAS. If the mother is emotionally unstable and requires rapid onset of analgesia, we begin the different combination of spinal epidural analgesia option. It is often dural puncture epidural in our clinical practice. If the parturience is closer to the second stage and cervix dilated is almost completely, we can use single shot spinal analgesia. However, the most preferred methods of maintaining analgesia is the program intermittent epidural bolus technique combined with the patient control epidural analgesia bolus in the patient requires. Why is this epidural mode so effective? To answer these questions, we need to understand what factors affect the quality of analgesia. The primary factors influencing local anesthetic distribution in the epidural space are the injection rate and bolus volume. A large volume or low concentration local anesthetic injected in a high rate significantly increases epidural pressure, resulting in a wider distribution area, including caudal, rostral, left and right direction. Unlike the continuous epidural infusion, this distribution area is significantly wider. It's the most important, resulting in a more effective sensory block. Accordingly, the next question is, how can we improve the quality of epidural? Okay, the answer is quite obvious. First, we use an automated epidural injection mode. Second, we ensure a high bolus injection rate from 100 to 250 milliliter per hour. And third, we individualized the dose and volume for each parturience. This is achieved by aiding a bolus administered via PCEA technique, patient control epidural bolus. As the local anesthetic, we use large volume, we use dilated local anesthetic solution of low or minimal low concentration with the addition of an adjuvant. But in Russia, opioid adjuvants are not legally permitted for epidural administration, so we use only local anesthetic. A specifically programmed intermittent epidural bolus technique meets this requirement. A specific infusion pump, for example, Medcaptain infusion pump, which are using in everyday our clinical practice, delivered boluses of local anesthetic at pre-programmed intervals. And women can also administer a PCA bolus to achieve the individual effective dose. The key advantages of this epidural mode include improved distribution of the local anesthetic solution, providing a wide area of sensory block, and maintaining motor activity during labor. The incidence of motor block is 10 times lower than with continuous epidural infusion. Our patient can be verticalized during labor, significantly improving maternal satisfaction. Furthermore, the study in 2025 published of urinary retention during labor with epidural analgesia showed that in women who received analgesia using program intermittent bolus, motor block of lower extremities was not observed in 97% of cases. Those women had no urinary retention during labor and therefore didn't not need bladder catheterization. The slide below presents our study on selecting the optimal combination of epidural analgesia mode and local anesthetic concentration. We study different epidural modes and levobupivacaine concentration. Group 5 is of greatest interest for us. The result of this study showed that the most optimal maintenance mode is the PIB mode, the red line on the graph. We achieved effective analgesia not only in the first, but also in the second stage of labor, which was possible with the programmed bolus mode only. In our study, we also confirmed another key benefit of the PIB mode, its hemodynamic stability. Our results show that only women in group 5 with programmed epidural bolus experience minimal change in NT-proBNP peptide level. All values of this peptide were within the reference range, unlike in the other group, including in the second stage. The NT-proBNP peptide has a vasodilatory effect and can contribute to increase hypertension, especially in the second stage of labor. However, women in group 5 had stable hemodynamics and no episodes of hypertension were recorded. In the end, in April 2026, the paper under the title From Labor to Surgery was published, demonstrating the benefit of program bolus not only for labor pain relief, but also for post-operative pain relief due to its key benefits. Thanks for these benefits, very high level of maternal satisfaction after childbirth was achieved. 77% of women rated the pain relief as excellent compared to patients with other groups who used different local anesthetic modes and concentration. These high levels of maternal satisfaction was achieved thanks to high quality pain relief and first and second stage of labor, minimal motor block, and the patient ability to move during labor, which ensure emotional stability and significantly reduce anxiety in our parturients. In conclusion, I would like to say a few words and show video about our everyday clinical practice in our department. We use both early and late epidural analgesia. We use the Stanford University settings for levobupivacaine mode and the University from Canada, Dalhousie University for ropivacaine for PIB mode. After inserting the epidural catheter, we administering a test dose and then water bolus, saline bolus. 4 or 5 milliliters of saline is injected to explain the epidural space and followed by the main loading dose of local anesthetic. Then we connect a specialized Medcaptain infusion pump. It's a simple, not expensive syringe pump operating in PIB mode. The infusion pump is mounted on a special stand, allowing the woman to move independently. Parturients can also mount her mobile phone on the stand. The stand also contains a visual analog scale and patient instruction for PIB and PCEA bolus technique. 30 minutes after administering the loading dose, our parturients stand up. We encourage them to walk or sit on a feedball as movement contributes to positive labor, to positive obstetric outcomes, and increase maternal satisfaction. We are ready to share our guidelines. We are ready to share our recommendation for PIB mode technique. We are ready the instruction for patient. You can see this instruction on the slide. And at the end of this video, you can see me and my daughter, who was born 4 months ago. I use a PIB mode for labor pain relief in my labor, and I can say that it was a wonderful labor, painless labor, and now we can see our video.
В нашем институте для обезболивания родов применяется самый современный метод эпидуральной аналгезии родов, программированный интермиттирующий эпидуральный режим в сочетании с болюсом по желанию пациентки.
Thank you very much for your attention.
Thank you very much for this. This is an excellent experience, your own experience, to be honest. And thank you very much, dear staff and faculty. And we have a couple of questions at the end of our conference. And let me introduce the first one. Maybe it would be some small discussion between faculty. Good afternoon. What's your opinion on a tranexam dose greater than 2 grams? 2 grams. This question about postpartum hemorrhage and the management of postpartum hemorrhage. What do you think? The question about the dose of tranexamic acid greater than 2 grams in the case of postpartum hemorrhage.
It's a question for Emilia, I think, yes, but...
It's just a small discussion between, for example, what do you think, Professor Gupta, what you experience in India, because I know that in India, sometimes a high rate of cesarean section and maybe a postpartum hemorrhage. What do you think about the administration of tranexamic acid in dose more than 1 gram, maybe 2 grams, etc.? Professor Gupta, do you hear us?
Can you hear me?
Yes.
Yes, 1 gram is routinely given, and after 30 minutes, if the bleeding still continues, then we give 1 more gram.
Mm-hmm. And I think the main point of this question about the safety and maybe side effects of the administration of tranexamic acid than the recommendation of dose. Maybe you have seen maybe side effect when you administer tranexamic acid in this maybe high dose, or no? And of course, Professor...
The major issue is you have to weigh between, the pros and cons. If there's a massive hemorrhage and patient doesn't stop bleeding, tranexamic is given. It is more of a theoretical, what I have seen in my practice is more of theoretical embolism risk there.
Sure.
But yes, it is ever present.
Mm-hmm. And Professor Kilichislan, what do you think?
This standard dose 1 gram intravenosus, of course, given as a slow injection over between 5 and 10 minutes. Timing can be important before skin incision, most commonly can be used, or immediately after delivery, after cord clamping. Repeat dose if needed. If bleeding continues, a second dose of 1 gram intravenosus may be given typically within 30 minutes to 3 hours after the first dose. And of course, use with caution in patients at risk of thromboembolism. Dose adjustments may be needed in renal impairment, and rapid injection can cause hypotension. Yeah, we can say like these things.
Okay, thank you. And let me introduce the second question, and it has been addressed to Professor Gupta. Are there any indications for awake intubation? Then patient is awake. Are there any indications to move to make this action?
yes, guidelines do advocate awake intubation in anticipated difficult airway where, the patient is cooperative and it is a category 2 cesarean section where the urgency is not there, because otherwise awake intubation is quite difficult to manage. And yeah, more importantly, they have to be cooperative. And the specific indication for awake intubation, yes, can someone else maybe throw light on that?
Mm-hmm. Thank you for your answer. And Professor Kirichislan, maybe you have something to add at this point. I can see. Okay. And Professor Kirichislan? No, I can see here. Okay, and the last question is, hello, could you tell me what this water bolus is instead of traditional test doses for epidural analgesia? It was addressed to Professor Kirichislan, but I can't see here. Maybe, dear colleagues, you could help to answer this issue.
Уважаемые коллеги, давайте я отвечу, наверное, на этот вопрос, и я отвечу все-таки на русском языке пока. Значит, что такое водная нагрузка или водный болюс? Это не так давно, на самом деле, методика появилась у нас в клинической практике. После того, как мы устанавливаем эпидуральный катетер, я вот сейчас об этом говорила, мы вводим 4-5 мл действительно физраствора интраэпидурально. Это делается для того, чтобы расширить эпидуральное пространство и тем самым увеличить площадь охвата местного анестетика, как я уже сказала, в растральном, каудальном, право- и левобоковом направлении, потому что широкая зона охвата – это всегда широкий сенсорный блок, и это всегда более качественная, лучшая аналгезия. Поэтому изначально мы и расширяем эпидуральное пространство. Кстати сказать, мы можем не отказываться от тест-дозы, она все равно должна быть введена, потому что это стандарт постановки эпидурального катетера, вопросов безопасности, поэтому расширение эпидурального пространства, тест-доза и дальше, опять же, нагрузочная доза, она идет большого объема, 16-18 мл, но минимальной концентрации. Именно за счет вот такой вот комплексной водной нагрузки, я бы так сказала, сначала вводной, а потом нагрузки местным анестетиком, мы получаем широкую зону охвата, хороший сенсорный блок, но при этом, поскольку это минимальная концентрация, это минимальный моторный блок, что позволяет нам поднять женщину через 30 минут после введения нагрузочной дозы.
Yeah, Professor Upryamova, thank you very much for answering. And we have no any questions from the auditorium. And they're extremely in time, and I really appreciate it because I understand you are so busy. And let me finalize our conference, our meeting, and thank you very much to all speakers for the insightful, highly relevant presentations, and thank you to all participants for your active engagement and thoughtful questions. Today's webinar has shown once again that modern obstetric anesthesia is developing at the intersection of patient safety, technology, multidisciplinary teamwork, and evidence-based practice. And of course, they appreciate your online participation, Professor Gupta, Professor Kirichislan, and thank you for joining us today. And of course, we look forward to meeting you again at our future scientific events, and I hope not online but on site too. And we're gonna to work on this one, and maybe some couple words from Professor Ekaterina Upryamova.
Thank you so much. It was an honor to join you all here.
Thank you very much for nice, very friendly inviting. This is most important for us. Collaboration is most important. Sharing experience is most important, I think. Thank you for your invitations, like these things, valuable meeting. Thank you very much.
Thank you very much, our speakers. Thank you very much, Professor Sunanda Gupta, Professor Banu Kalichislan, Professor Emilia Guash, Evgeny Verenkov.
Thank you.
Thank you very
Thank
much,
you so
our
much.
moderator, Roman Kapustin. Thank you very much, technical service, and Anna Volchenkova. I think that webinar is excellent, is useful for us, and see you soon and see you again in the next time. Thank you.
Thank you.
Soon.